4584 Semrad Confrence. Tape 1.
I'd like to turn the program back over to Ms. Miller-Havens. Susan?
We have two discussants and two formulators. We're going to start first with Dr. George Valiant, who's the Raymond Sobel Professor of Psychiatry at Dartmouth Medical School, former Director of Training at Mass Mental Health Center. I'd like to mention that on page 17 in your syllabus, the faculty who were associated with Dr. Semrad over the years have given us the years that they were associated in what capacity. And you might like to refer to that as you hear from them. George?
I'm going to give two formulations, the first very brief and in the inimitable style of DSM-3, where the task is simply to make a diagnosis and predict the course. The reason I'm giving two formulations is that no single approach to the patient, as Les Havens has instructed us over almost 30 years, holds the whole truth. The first formulation is simply this is a woman that's had 3 psychotically depressed relatives. She undergoes the trauma of childbirth with its hormonal irregularities, and she has a postpartum depression that in the world of DSM-2 and Mass Mental Health Center at the time is diagnosed as schizophrenia, but a schizophrenia that is absolutely certain to remit if left by itself. She has a good premorbid adjustment. She has depressive symptoms. She has a clear precipitant. She has psychotically depressed relatives. She has an acute onset, a high IQ, and a concern with death while psychotic. And then, in spite of being diagnosed DSM-2 schizophrenia, she's treated with tofranil. Fine. So we've got the course and we've got the diagnosis, and we're left with very little. Indeed, I might say that there's an article in this month's American Journal of Psychiatry that suggests that the disadvantages of this kind of thinking outweigh its advantages. The second formulation, before I offer it, I want to interpose a little bit of theory. Psychoanalysis often gets in trouble because it confuses metaphor with myth. Taken too literally, the myth that separation and loss is the cause of all ills leads to the almost parody of a resident helping a patient grieve the loss of a resident who'd helped her grieve the loss of a resident who, so on, back through history. Is loss the issue or only a metaphor for what we're really talking about? Nothing, no one who we have ever loved is really lost, and you can't lose someone you never loved. Consider the situation of the aviator in The Little Prince. The aviator is losing the Little Prince forever, and the aviator's life is forever enriched, as long as the aviator can remember the connection between the wheat fields and the Little Prince. When I left Mass Mental and believing the way Semrad talked to be myth rather than metaphor, and I was trying to study mental health in a group of college men who had been followed for 40 years, I added up the number of years that the men had lost, been orphaned in childhood, and then to be on the safe side, added up the number of years that their parents had been orphaned. And if you took the men who had the very best outcomes and the very worst outcomes, loss of a parent, the amount of time that you'd lost a parent, had no effect on outcome. If we move from that rather scanty research to Michael Rudder, who carried John Bowlby with him when he set up research, and in a very systematic way, pointed out several facts. Premorbid vulnerability or conflict causes painful separation, not strength of attachment. A conflict-ridden surviving parental marriage produces far more pathology than parental death. Bonds can be kept alive by fostering them vis-a-vis the Little Prince and vis-a-vis, I believe, the kind of work that Semrad showed all of us how to do. There's a difference between privation and deprivation. Privation, what you never had, can leave permanent scars. Deprivation leads to distress, suffering, but not necessarily damage. And finally, failure to form bonds is far worse than forming bonds and then having them broken. Okay, let's return to the formulation. One of many, as I suspect we will see as the subsequent formulators and discussants come up. This woman feels empty, far from her husband. And yet, in a strange way, she feels empowered by a baby that allows her to bring joy to friends over the telephone. In the residence formulation, suggests that the baby aroused in her her own desire to be a child again and gain the love initially denied her. This becomes clearer in Semrad's interview, where I think he suggests to us that a major task of psychotherapy, major task of dynamic psychotherapy, and the way that it helps to heal us or ourselves to heal ourselves, is that it allows us to discover the people that we loved and forgot that we loved, not to help us mourn those that we've lost. That the work of mourning, the work of grieving, what Semrad is saying as a man who appreciated that poetry and metaphor allowed one to talk more readily about truth, that mourning is simply the flag, the metaphor for helping people rediscover internalized objects. This is a woman who grew up in a disorganized home where she admits, even as a child, the crowding meant raising mental barriers. I was closed up and dazed. Her defensive structure. Semrad suggested that what's important is not what's outlined in the DSM-3. What you have to know to understand, to diagnose a patient, is to understand something about their defenses and something about their internalized objects. And starting first with the defenses, this is a woman who's obsessional. When she's functioning well, she used the defenses of reaction formation, isolation, and displacement. And then a bell jar descends over her, which she describes vividly, the problem when you take obsessional defenses too far. And perhaps it's no accident for us to remember that part of Sylvia Plath's getting out of her bell jar was to go to a grave and grieve a father whom she thought she only had negative feelings towards and wished dead. But distance for this woman is important always. She lives in a separate bedroom from her husband. But as the psychologist says, in spite of her distance, she has strong feelings about these people. She then has a baby which produces conflicts, reminds her of the fact that indeed she loved her father. It reminds her of, in fact, she hated and had contempt for and felt neglected by her mother. It reminds her that she has a rival for her husband who's distant enough. And perhaps just as bad as anything, it breaks up her routine, and obsessionals don't like that. So where isolation shifts to the next lower level down, and in talking about shifts in defenses, this is pure Semrad. He figured it out and observed that one can see in the recovery from psychosis an upward march in the patient's defensive structure. And in this patient, we can see the defenses move both ways. So she goes from isolation to fantasy. I daydreamed a lot. I had imaginary conversations. And in her isolation, maladaptive isolation, her fantasy, she loses the capacity to reach other people, which is one of the problems of the less mature, the more pathological defenses, is they come between us and objects. So that this woman who, in the interview, is obviously a dear, but she manages to make her therapist angry at her because she's so aloof and seemingly unreachable. When she says that she's empty, as her defenses slip back, he doesn't hear it as reaction formation. You look at the way she talks about her feelings to Semrad. I didn't even have a teeny weeny bit of love for him. No, doctor. I mean, you can see the reaction formation. We can understand reaction formation. We can forgive reaction formation. But as her therapist hears it, she is emptied and she devalues and she splits. And much of our myth about borderlines is indeed they never had objects, rather than when some beloved objects get too hot to some people, as she does, she walls them off. They don't exist. Again, in her projective testing, she tries to cope with threatening stimuli by denying their impact on her, and so she's empty. And again, the displacement. This girl who grows up in a house where the toilet is always full and finds solace doing hard work in a disinfectant factory and worries not about this exciting baby that she admits brings joy to her husband, and even the nurses are turned on by this baby's capacity to evoke love. Instead, she becomes concerned with bowel movements. That's displacement when she's functioning well. It then merges with projection and finally delusions. Well, what Semrad does is get her to admit this empty woman. And this empty woman who, if you have available, you may not, her therapist has 3 questions for Semrad, each of which have to do with the patient's anger and what the dangers that she poses to herself and others. And so Semrad, early on, and undoubtedly with help from imipramine, gets her to admit that the problem with her baby was that it was too easy to love. And then, using respectfully the defense of displacement, puts her back in touch with a man who she once loved. Here is a patient being presented because they're so angry. And what's Semrad's key Question: have you ever been in love with anyone else? And so memory expands to touch on memory. It's not all spelled out, but the point of a metaphor, unlike a myth, is that you have to keep saying it. That metaphors we say over and over again, like refrains to songs, like the themes in symphonies. So as the interview goes on, Semrad keeps playing the same questions over and over again to help this woman not to mourn her loss, but to rediscover people whom she loved. And I don't know if Harold Searles will tell the story tomorrow, but last week I heard him describe a wonderful description of a person who was having difficulty dealing with the death of a father who seemed to be hated, and discovered the amount of care. And he described it with, again, a metaphor, not a psychoanalytic myth, a metaphor of a grandfather rabbit dying. And when the grandfather rabbit dies, he turns into a sunset, which is permanent in its impermanence. Thanks.
Dr. Jerry Adler will be our next formulator. Dr. Adler is a lecturer in psychiatry at the Mass General Hospital, training analyst at the Boston Institute, another trainee, former trainee. Jerry?
Well, Semrad was a natural and came from a natural farm surroundings, as he liked to tell us. And as a natural, he would approach patients and teaching about the patient in a way that made us, his students, ready to understand not only the patient and ourselves, but also a lot of the contemporary theoreticians and clinicians who were writing, and I think also the people who have continued to write. The people who I think are relevant are people like Ballant, Winnicott, the existential analyst, Heinz Kohut, and a lot of the very complex object relations theorists who we try to struggle to understand. The popular term now, the empathic approach to the patient, I think was there in a lot of what Semrad did. Looking at things from the patient's perspective was intrinsic to his work. I remember when I was a third-year resident at the Wednesday noon conference, sitting next to Semrad when I think a Swiss existential psychiatrist, Maynard Boss, was there. And Boss told about this really interesting patient that only he could work with and only he understood, and he was going to tell us why he understood the patient and why he could work with her. This was a woman who was seen by a number of psychiatrists because she had the fantasy of wanting to stab her baby. And Boss, said that all the psychiatrists were saying that she had all these murderous impulses toward her baby. And Boss said that he, in his work with this patient, found that he got in touch with her and found that her wish to put this knife through the baby was her wish to make an emotional contact with this child, and that's what worked. And he then said that his position of being in touch with the patient and the meaning of the patient's inner life was what he had to bring to us. So I whispered to Semrad, isn't that what we do here? So Semrad whispered to me, well, why don't you tell him that during the question period? And I whispered to Semrad, well, why don't you tell him? And since both of us were very shy people, neither of us told him, but we both knew it to be true. I thought that what I would do as part of trying to get to a formulation is try to describe and discuss some of Semrad's theoretical and clinical ways of looking at things. Semrad emphasized the careful empathic diagnosis of the patient based upon a really careful empathic history taking. He always emphasized the importance of the formulation and the diagnosis and the treatment plan coming out of this formulation. I say this with emphasis because surprisingly or shockingly, you don't hear about that so much anymore. Also, as part of what he stressed, there were vulnerabilities that came from the patient's biology and that came from the patient's early experiences, and there were precipitants that led to a psychotic decompensation in a vulnerable person, and that these events, the precipitants and early experiences, also had very personal meanings to the patient. For the psychotic patient, Semrad emphasized that the psychosis vulnerable individual lacked the ego capacity to acknowledge, to bear, and put in perspective depressing events associated with disappointments in relationships, and these depressing events were accompanied by aloneness, depression, and loneliness. Semrad stressed the avoidance defenses. He called them the narcissistic triad: denial, projection, distortion, so that people who had to deny what they couldn't bear turned to an inner world of compensatory fantasy to deal with it. The therapy had to address these avoidance defenses. Another defense that he talked about was identification with the aggressor, also a major defense. He stressed the developmental failure that was part of the vulnerability of the patient. He described the families of future schizophrenics as people who utilized primitive modes to avoid pain. The intense feelings of childhood in these people were handled by ingestion, not digestion, his terms. And here's a Melanie Klein kind of concept of an early object relations model of a bolus that was walled off rather than digested and assimilated. That for these people, survival in childhood and later required conformity, and that the child's rage was contained by denying the ambivalence and by splitting apart affects, again, all these object relations terms, and maintaining the deception required of conformity because of the child's neediness. This symbiosis was rewarding for both the parent and the child, until the child became aware of the price paid for it. Then there was an emergence of annihilatory rage, which left the child unprotected because of the primitive, fragile defenses, the poor capacities to relate, to tolerate delay, to bear affect, or to sublimate. These were people who felt helpless, worthless, ineffective, and had to, because of their lack of developing ego capacities, had to deny or project rage. The world for them became hateful and malevolent. And with the loss of the object, or the object support, a decompensation that was psychotic occurred. To quote Semrad, for those psychosis vulnerable egos, psychoses are the extreme, grotesque, and pathetic disasters revealing flaws in development which had often remained inapparent. Now, Semrad, as we know, emphasized the precipitants. They were disappointments in or loss of a sustaining or supportive relationship, or ambitions which outstripped the human supportive structure or the person's capacity to maintain objects within him to comfort and soothe. There was a personal meaning of the loss, which could appear very minimal to others, but were significant to that person. The losses were loss of a parent, a spouse, or, as we see in today's patient, a new child that gets between two people, loss of a lover, any significant other, or the loss of a child, for example, through the child's growth of separation individuation. In adolescence, the loss of a supported family structure in an ambitious adolescent who needed the family structure and who would go off to college, for example. Semrad stressed the simple things, the loving the disappointments in loving, disappointments in work, and the kinds of disappointments that a vulnerable ego could not tolerate and contain. The rage following the loss triggers the psychotic vulnerability and leads to an intensification of avoidance defenses and the acute psychotic decompensation. Now, when you look at Semrad's writings and listen to his discussion of patients, my sense was that he took Freud's model of grief and mourning in Mourning and Melancholia and applied it to psychotic patients. So let me review Freud's 1915 paper briefly and see what Semrad did with it. Freud talked about the distinction between normal mourning and depression. Both of them have a profoundly painful dejection, a loss of interest in the outside world, a loss of capacity to love, with an inability to turn to a new love object, an inhibition of all activity. These are the parts common to both. But in melancholia, you see self-reproaches, self-reviling, which can lead to a delusional expectation of punishment. Therefore, with the melancholic, there was a serious disturbance of self-regard. As Freud defined the mourning work, reality testing shows that the lost object no longer exists, and that libido should be withdrawn from that object. However, in every person, there's opposition aroused. To quote Freud, people never willingly abandon a libidinal position, not even indeed when a substitute is already beckoning to them. This was a quote that a contemporary of Semrad's, John Murray, used to love to mention again and again about the way people just stick with a position they have and can't budge from it. But however, normally reality wins out. Quote Freud again, each single one of the memories and expectations in which the libido is bound to the object is brought up and hypercathected, and detachment of the libido is accomplished in respect to it. Close quote. The ego then becomes free and uninhibited again. However, in melancholia, this doesn't quite occur. The issue is not necessarily death for the melancholic, but also loss of love. With the melancholic, the person usually can acknowledge who is lost. The problem the melancholic has, he has trouble acknowledging what the significance of the loss was to him. And that significance has been withdrawn from consciousness. As we'll see in schizophrenia, even the whom is problematic. Now, in the mourning in the melancholic, the patient presents his ego as worthless, patient reproaches himself, and presents characteristics of himself that are similar to the lost object. In Freud's formulation, the libido is withdrawn from the object, and there's an identification of that object in the ego. And a famous term, the shadow of the object falls upon the ego, and that there's a self-critical agency called the superego that torments the object. This is the beginning of Freud's object relations approach to intrapsychic issues. And Freud, as part of it, emphasized the importance of anger and sadism, the inability to tolerate ambivalence, and the narcissistic quality of object relations. Freud's position was in many ways used very much in the way Freud described it by Semrad. Now, this is the way my understanding is of how Semrad applied it to the schizophrenic patients. Semrad saw that schizophrenic patients also have these conflicts due to ambivalence, but the schizophrenics use these avoidance defenses: denial, projection, distortion. For schizophrenics, the work was to help them acknowledge the loss, the who is lost. In addition, to acknowledge and bear with them the what, the significance of the loss for them without projecting it and without distorting it. The schizophrenics cannot acknowledge and bear thinking about the specific details of the lost person, and the affects associated with the specific details of that person. And as Semrad defined it, the schizophrenics need specific help with the work of mourning that normals can do by themselves. The schizophrenics require a sustaining relationship that offers this appropriate support so that they can do the work of mourning that normals can do. Now, in getting to Semrad's clinical work with patients and his style, there are certain dilemmas that he poses for those of us who have tried to understand it. Because a major problem in working with very primitive patients is, especially the psychotic ones, is what Burnham and Gladstone have called the need-fear dilemma of the schizophrenic. The schizophrenic longs for the closeness, longs for the attachment, and yet for the schizophrenic to want this closeness, there's an oral and corporative issue which leads to a breakdown of ego boundaries and a terror of psychosis and actual psychosis that the closeness can bring through the incorporation. In object relations terms, there's a loss of self-representation and object representation, the loss of ego boundaries. So that the way that a person like Semrad could get close could threaten the ego boundaries of the psychotic person and lead to a psychotic decompensation right there. Now, why didn't that happen with Semrad in his work with patients? My sense is that there was something very implicit to Semrad's style that on one hand offered this empathic, reaching out, supportive approach, and at the same time everything that Semrad did simultaneously supported the mature aspects of the patient. And let me define that from Semrad's style and from the specific interview. Over and over again, you could define practically everything Semrad says in some way helping the patient to observe, an observing ego stance that Semrad supported, looking, noticing, evaluating, understanding. Take right at the beginning, he says to this patient, have you prepared yourself? Later he says, so you have noted this change on your part to a positive attitude. A number of comments about observing, supporting an ego function of observation. Then there's another part, the support to make decisions, a decision-making stance, both for the patient and the patient's view of others. Over and over in this interview, Semrad says things like, how did you decide that? Have you decided to work at it? You were undecided? Then how did he, the pediatrician, arrive at that conclusion? Supporting the ego function of making decisions, being a separate person who is not this helpless, merging, psychotic person, but a person with the capacity to observe and decide. Then there was the stance of his work of helping people take responsibility for themselves, their actions, and their feelings. As residents, we all would joke about the famous Semrad remark of to the regressed psychotic patient, how did you arrange it for yourself to come here? This patient who ripped off his or her clothes and ran down the street, how did you arrange it for yourself? That was implicit in everything he does in an interview. He says to this patient, could you give me some indication of what you have done for yourself since you have been with us? That this woman has to take responsibility for herself. Then there's another implicit thing about Semrad's work, which is an attitudinal thing in everything he does too. Then his position of not understanding something unless he has the data from the patient. He doesn't make the giant empathic leaps of knowing what's on someone's mind. He's got to hear it from himself. He's the dumb therapist who's got to be told, otherwise he doesn't know. For example, in this interview, the patient says, I should answer that question, as she first avoids. And Semrad says, it would help me. That unless you tell me, I won't know. I don't go beyond the data. I may have hypotheses in my head, but unless I know it from you, I can't make those leaps. That's also a stance that deals with two people who are separate at the same time that he is getting in there and close. As we all know, his stance of putting feelings into words and helping patients defer actions are crucial. The issue of acknowledging and bearing, as he says in this interview. Did you talk about things that really mattered to you? He talks about the disappointments this woman had in waiting 7 years to have a baby. He helps her acknowledge her longings for her first love. He helps her acknowledge her husband's joy in having a daughter compared to what he's like with her and the pain she experiences with this. He helps her talk about the sharing of the love with the baby and the issue of the heart versus the head. Does your heart know you could care less, for example? That's related to what has been mentioned as the body tour. That as relevant to Freud's work, Freud says the ego is first and foremost a body ego. Semrad really believed that affects are tied up with body parts, and Semrad in his interviews would get to those body parts. Major part of his stance is what he called giving with one hand and taking away with the other. And I think this probably, for those of us who could watch it and learn, was one of the most valuable aspects. How do you offer optimal support and at the same time frustrate optimally? And how can you ask the most painful things that you know undermine when at the same time you want to offer the support to make that possible without a decompensation of the patient while you're doing that? With that as a long introduction, let me just briefly say something about the formulation of this patient. Semrad got so beautifully from her, she was aware that her husband's joy in seeing this new daughter was very different in the way his response was with her. And that what she had so much trouble with was the envy and the anger at her daughter, who was getting more than she was getting in the marriage, and clearly getting more than she had gotten from an alcoholic father and a mother who needed a mother more than could be a mother herself. It sounds as if the 7 years of difficulty in getting pregnant meant to her, as was implied, that she was out of favor with God, and that all the issues of her tenuous self-esteem were tied up in that if she were in favor with God, she could have that baby. As part of her vulnerability, she grew up in a family where action and avoidance defenses were predominant. Hate was more powerful than love in her family. Seeing herself as a mother, as a hypercritical person with low self-esteem, was extremely painful for her. Her own ego ideal was that she was going to be a person who would be the perfect mother, having had experiences of seeing what imperfect mothers were, and feeling about herself that she had become a shrew, and that she was an angry person, a shrew, a critical person, was intolerable. She who had to be a caretaker to her own mother, and that she also hated her father. And what I would question was that rather than that she was praying him out of purgatory, I think that she had a unforgiving feeling about her father, and her confusion about how you get somebody out of purgatory and whether they get out of purgatory or not. I think she knew that you pray people out of purgatory, but I don't think she knew yet that whether she really wanted to pray her father out of purgatory. And I think that her hate overwhelmed her love for this father, as well as for her child, as part of her psychotic decompensation, as well as for her husband. And that the hatred toward the husband and the child reactivated the hate toward the father and mother, and the tremendous guilt she had about this hatred. You can see in my formulation, I'm underlining one part that I think Semrad didn't emphasize in the interview, and could be a question to raise about Semrad's view and ways of working with psychotic individuals. That her hatred and unforgivingness I think were paramount. Now, in the interview, she implied that, talked about it, acknowledged it, but that's something Semrad didn't follow. Now, to understand that, my sense is that Semrad knew that unless you helped somebody see the good in the other person, the acknowledgement of the murder was intolerable and could lead to a psychotic decompensation. The question to raise, though, is did Semrad, in a persistent way in his work with patients, go after the aggression, did he, in supporting with one hand, supporting the good, at the same time, did he go after the negative affect, the aggression, the murder? Because a question could be raised about this interview. In not acknowledging the hate that this woman felt, did she feel misunderstood in some way during this interview? The sense is not there that she did, but that would be a question in terms of somebody who worked with her later. Was it crucial for the therapist to acknowledge the hate as a major part of it? What I finally want to say is that I think that Semrad, in his own style, presented the theoretical model and the clinical position that many other people have written about, and that the work of Winnicott, the work of Kohut, Ballant, many others, is all there in Semrad's work. His gift was not to write about it in papers. His gift was to show us how to do it. But I think that he has helped those of us who have tried to understand the others. He has given us the way to understand their work, and has also helped us to bring his understanding of psychotic people to a whole variety of patients. Thank you.
I'd like to introduce Dr. Max Day, the Assistant Clinical Director of Psychiatry at the Mass General Hospital. He's on the faculty of the Boston Psychoanalytic. He, for many years, was both a colleague and friend of Dr. Semrad's.
Friends, I want to warn you, I've just been elevated to eminence. I'm only the assistant clinical professor, not director of psychiatry at the Mass General. Tom Hackett would be very shook up if he found out that I was the other. I'm reminded of when I was to read a review of a paper for Semrad when he was sick. And he said, be sure to criticize this guy for sending in the paper only a week before you were supposed to review it. I thought of that this week since I got a one-page summary of Dr. Adler's report 2 days ago and nothing from Dr. Valiant. Then I thought of myself. I got up at 7 in the morning on the 1st of January, flipped the disc into the cassette recorder, and heard Semrad say, won't you sit down? We've been talking about you. And I choked up and closed the tape player. I was going to call up Susan Miller and tell her, did you know what just happened? But it was too early in the morning. So I guess that it was hard for all of us to read or write this down in advance and send it in like something else. I think he was one of the most sentimental men that I've known, and his wife recognized him as such, and in a rather peremptory way occasionally kidded him about being a sentimental slob, which was a compliment. And I think it's very hard for us to lay him to rest, to put another nail in the coffin today, and I think that's why I didn't get the reports in advance. So I had to sum up my own notions about this interview and the formulation on the bases that I've told you. I think there must be about 5 or 6 sets of factors in understanding some of his views and some of his approach. One has to do with his personal history. A second has to do with the concepts that he was taught, that he had to begin with. Third, I would include the patient population. Fourth, the personal equation, the man where he was in life when he was saying the things he was about this patient to this particular group of residents. And fifth, the concepts that he developed in time. Many of those have already been highlighted by some of the speakers before me, so I won't even have to pay too much attention. Let me turn first to the personal history. He was described, I believe, as not being a fighter. I think he's one of the toughest fighters I've met in my life, and I think the patient felt that. The resident population always felt it because they empathized with the poor, helpless patient who was being pushed into a corner and driven into the side pocket by this master pool player in every interview. People would come and foam on the couch after they would witness an interview as if they had been mauled by Semrad. So that he had a powerful impact. There must be many ways of fighting. Now, he came from a Czech background out west, a Catholic background, and this was very important. The closest thing that many of us know about in this country is the usual picture of religion amongst the French people in France. The women go to church, and the men go and have some wine and scoff at it, but are secretly connected with it. I think this was the kind of connection he had. He would drive his wife to church every Sunday. Sometimes he'd go to church himself and listen to the homily and try to apply it to his own personal current dilemmas in life. He was not a believer. I think he was frank with Father Sullivan, who I believe is in the audience, in saying that I've never heard him or seen him, and I haven't experienced him. And yet he was never detached from it either. He helped me personally understand a great deal about Catholicism that I'd never even dreamed of before.